Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Dr. Izzat for inviting me for this marvelous gathering. My talk is about intestinal ultrasound as a non-invasive tool in pediatric inflammatory bowel disease. لحد قريب كان عندنا الكونسبت ان الالتراساوند از انمي فور اني اير كونتيننج اورجان، بدات تتغير الفكره دي والعكس. انا اريكومند الالتراساوند فور اي بي دي بيشنت فور ات ليست 10 ريزونز، هتلاقيهم كلهم منطقيين وابليكابل. It's real time, non-invasive and rapid technique, accessible and available more than CT and MRI, relatively low cost, no contrast hazards, no ionizing radiation hazards, requires no sedation or anesthesia. It's repeatable, and this is a very important point for this patient in the follow-up and monitoring therapy. It's bedside in ICU patient, for example, and on-spot reporting. No preparation, no enema, for example, and in case of poor renal function, it not contradict with contraindication. But everything have the other phase, some disadvantages for the ultrasound, including inability to visualize some parts of the small bowel, rectum, and sigmoid colon. Difficult tracing in one scan of a long segment, so the actual length may be deceiving compared to CT and MRI. It's operator dependence, of course, depending on the skills of the ultrasonographer. And lastly, and most cut-off values still under research. How can I do ultrasound bowel? First of all, no need for preparation, no need for fasting, no need for urine retention. I do by manual anterior and posterior compression technique to help displace air and displace the normal bowel loops and to enhance the affected segment. I use high-frequency probes that can visualize and characterize changes in the layers of the bowel wall. For my work, I use initial convex abdominal probe to survey the abdomen, followed by the linear probe, 7.5 megahertz. And in some places, this expensive hockey stick probe can yield more informative data. The technique starts from the left iliac fossa to trace the sigmoid colon and its characteristic rostral pattern. Then I go in the left side of the abdomen to trace the descending colon. Then transversely, the transverse colon. The right side ascending colon. And lastly, and the most important, is right iliac fossa containing the terminal ileum, cecum, and appendix. By ultrasound, we have this gut signature to trace 5 layers dependent from each other, alternating. The lumen starts as echogenic, it means bright. The lumen is bright or white central zone, followed by the mucosa, which is hypoechoic black zone. Then submucosa alternating white zone, and the muscularis propria is the peripheral black zone. Lastly, the serosa is the outer coat white zone. In my normal report, I must comment upon the bowel wall thickness. It must be less than 2.5 millimeters for the pediatric age group in the small intestinal parts. For the adults, we accept till 3 millimeters, and less than 2 millimeters regarding colonic segments. As we say, bowel wall stratification must be preserved, peristalsis and the compressibility of the segments must be preserved, and using the capability of power Doppler and color Doppler, we see each segment. Normal bowel does not show much vascularity, and therefore, if I notice hyperemia, it denotes inflammation. How I comment in Doppler, either subjective or qualitative by visual inspection degree of vascularity, or objective and quantitative by measuring the flow velocity and the resistive index in superior mesenteric artery. What are the spectrum of findings? Of course, it will depend according to the presentation. Early signs of disease activity, first of all, is segmental bowel thickening. The affected segment will be a second inflamed, hazy. Second is a bulboidal mucosal changes with alternating areas of normal and inflamed edematous mucosa, giving the cobblestone appearance. The characteristic for Crohn's is skip lesions, but transmural involvement. However, on the contrary, ulcerative colitis is superficial but continuous lesion. Haziness is a very important sign. And lastly, hypervascularity, as we said. In early Crohn's disease, for example, which is more dangerous, of course, the wall stratification is usually preserved and submucosa is thickened, appeared like this as a thick band of hyperechoic band appears bright, as we said. Later on, the stratification will be lost, as we will see. This is active Crohn's in terminal ileum, and using the power of our capability of the color and power Doppler, I trace hypervascularity in all layers of the affected segment. One of the tricks of the technique to do intermittent graded compression. This is important. Here you see the normal segment superiorly, and they call the affected Crohn segment in the middle, and inferiorly it is the iliopsoas muscle. With graded compression, I will obliterate and compress the normal. However, the inflamed segment is still poorly or non-compressible. This and the inferior images reveal the difference between the normal and pathological segments during compression. Again, this is to trace normal that will compress completely to be slit-like with preserved linear lumen. On the other hand, poor or almost no compressibility of the affected segment. For this case, I see and trace inflamed edematous acutely affected segment and trace the affected wall. Same case in CT, less defined, less characterized compared with ultrasound findings. Characteristically in Crohn's, as we say, skip lesions, alternating areas of clearly normal parts with inflamed parts, sharp demarcation between both, and also ultrasound can detect ulcers as echogenic, bright, eccentric focus within the mucosa that is black. This disturbed continuity of the epithelium is the definition of ulcer. And this yellow arrow refers to the creeping fat sign with proliferated fat surrounding the inflamed segment, as we will see. With complicated cases, this is important transmural signature, involvement of the mucosa by hypoechoic ulceration and inflammation that goes to form sinus defect with air coursing outside the lumen of the affected bowel, abscess collection, and fistula between two affected segments. On the other hand, I can trace stricture as a long segment like this of fibrotic, followed by or proximal dilatation aperistaltic segment with bowel obstruction. Fistula with the bladder, fistula with the skin, enterocolic or enterocutaneous or enterocolic or enteroenteric, all of these are nicely demonstrated by ultrasound. With chronicity, there is loss of stratification. There is fat deposition within the wall of the affected segment, traces here as bright layer and seen hypodense in CT, and fibrofatty proliferation surrounding the affected segment, trying to wall off the inflammation and prevent perforation. Again, as you know, in ulcerative colitis, the lead biome ahostral aperistaltic colon with dilatation and associated leukoregional adenopathy. The most common differential diagnosis with Crohn's is infectious enterocolitis, as my colleague said, but here it's totally different, no involvement, the fat is clear, no abscess formation, no fistula, only submucosal, and all layers intact, and here the colon is affected more than the ileum. To take home message, pediatric bowel ultrasound, helpful initial diagnosis, detect extent, activity, staging. Color Doppler can also increase inflammation and decrease with regression. Promising techniques like contrast enhanced ultrasound to the left, injecting contrast and traces by ultrasound, and ultrasound in elastography to detect the fibrotic hard segments can be also used. And this is my last slide, demonstrating how to follow up patient with inflammatory bowel disease, followed with treatment for 12 weeks with partial improvement, and at 26 weeks by total improvement, and this is correlated with endoscopic images as you see. Thank you so much.
شكرا دكتور احمد، الالتزام بالوقت. Thank you.